So this talk is about the case for investing in community health navigation programs. And my name's Mark Harris. I should have introduced myself earlier. I'm Executive Director of the Centre for Primary Healthcare and Equity here at the University of New South Wales. And thanks. Great. We're kind of making this up as we go along technically. Thanks very much. So today I'd like to talk about the rationale behind community health worker navigation programs, review some of the evidence of their impact, and discuss what's required for their implementation and sustainability. So the context of this, of course, is that we're in the health system coping with increasingly complex problems and increasingly complex care needs. And this is due to both the increase in long-term conditions and multimorbidity and both the success and complexity of health interventions. So people are surviving that longer and living longer, and as a consequence, we're dealing with more complex problems. And these are also confounded or compounded by socioeconomic disparities, the diversity of culture and language in our society, and the social and physical environment. The structure of the Australian health system is itself very complex, with divisions between levels of government, as well as between different types of funders, including government and private sector funders, and the involvement of non-government organisations. And corollary of all the increased complexity is increased difficulty in navigating the health system. This places demands on patients' health literacy, which are often not able to be met, especially for disadvantaged and vulnerable population groups. It can act to prevent patient-centred care and prevent self-management, which we all know is critically important. The health workforce shortages are already a major problem in rural and remote areas, primary health care, and they're predicted to worsen even in urban areas, especially in general practice over the next decade. This reduces our capacity to respond to this complexity and to support patients adequately to navigate the health system, as well as, of course, building their health literacy. Funding models don't adequately support complex care. There's also evidence that there's, for inverse care provision, and by that I mean that people's care needs are not being fully met, particularly disadvantaged and socioeconomically vulnerable groups. So community health workers can help us to address some of these problems. The community health worker role is not new. They've been used since the 1960s in the US in poor and ethnic communities. And they're called by a variety of names, and they're serving different populations and providing a range of health and social services. Today, community health workers can be found in many countries in a wide spectrum of settings, such as community organisations, health departments, churches, schools, clinics and hospitals. Their role include providing outreach from services, education and behavioural counselling, identifying and addressing barriers to access care, providing navigation support and follow-up care, identifying and linking to community resources, and acting as a bridge between consumers and communities and the health system. In Australia, we have a long history of Aboriginal health workers and other lay and peer workers, although they've not always been called community health workers, and their role in the health system as a formal role hasn't always been acknowledged. the title of this talk was about the case for community health workers, and obviously the case is related to need, but it's also related to their effectiveness. And there's increasing evidence, particularly from North America, of their ability to improve access to care, including preventive care. So that includes programs like smoking cessation, cancer screening, and improving continuity of care with primary healthcare services. They have supported patients to better self-manage their chronic conditions, resulting in better control of diabetes, cardiovascular disease, chronic respiratory disease, and a range of other conditions, and also improve satisfaction with their care. There's some evidence for their impact on health services, particularly decreased use of secondary and tertiary care services, especially emergency department use and hospitalisations. Similarly, there's evidence for improved quality of care and that they represent good return on investment. So these are just two examples of return on investment analysis in two programs in the US which have involved community health workers acting as navigators for patients based in the community. One from Colorado, in which community health worker roles were very much focused around assessing social care needs and providing support for patients to address some of those needs. The return of investment in this particular program was $2.47 US for every dollar expended, and that represented a 36% reduction in healthcare costs, largely due to reduced hospitalisations. Another example is the Arkansas Community Connector program, and in this the role of the community health worker was to identify needs of people with long-term care needs that were unmet and who may be at risk for entering nursing homes. And they were provided with home and community-based long-term outreach care which connected them to community agencies offering needed services. And again, the return on investment was around $2.92 US invested, or about a 24% reduction in average health expenditure per participant. So there's many other examples of this sort of evaluation that's been done on community health worker programs, both in the US and Canada, and showing similar levels of savings in health expenditure. The other important aspect of community health workers, and the important reason for investing in community health worker programs, is that they represent an important tool for addressing health equity by the health system. Community health workers are able to reduce barriers to marginalised population accessing care, and this has been demonstrated with refugees, Indigenous populations particularly, and addressing their disadvantage related to education, low literacy and health literacy, language and cultural differences, discrimination, poverty and disability. Community health workers have also been demonstrated to be able to work with both individuals and communities to advocate for change, to take into account cultural and language differences, to address poverty and discrimination, and to build the capacity of those individuals and communities to work with the health system to improve their own health. So what do we need to make this work? Community health workers, first of all, need to be adequately trained. Not so much in clinical care, particularly because most community health workers don't have roles in providing clinical care, but rather working with patients to address barriers to their access to care. And so the education needs include providing background information on illness and disease and screening and risk factors and so on, but also educating and developing patient skills and trying to make sure that patients' needs are adequately addressed by other parts of the health system. They also need supervision and support as part of a healthcare team, and this is especially important if their role is to be sustained in the long term. It's important also to make sure that they're supported so that they don't burn out. There also needs to be a funding model. In Australia, this could take the form of a Medicare payment, and these are currently possible for Aboriginal health workers who provide care as part of team care arrangements, but not for other kinds of community health workers. Another model is for them to be directly employed by health services, local health districts. There's an example of them being employed by primary health networks and non-government organisations. The latter is common in the US, and we'll hear perhaps from Alex a little bit about that later, where many community health workers are employed by faith-based organisations or community organisations or medical centres working with disadvantaged communities, and they're funded through a variety of state and national programs. In New Zealand, and we'll hear from Fiona about one program in the South Island of New Zealand, but there's also been community health workers employed in the Maori and Pacific Island communities with funding from district and ministry health services. But we also need to, community health workers need a place in the health system. And I guess one of the challenges we've had in the past in Australia, particularly with so many different names and roles for community health workers, that's often been linked to particular conditions or particular services. And so developing momentum and developing the sort of systems for training and support that are required and funding is difficult when they're very narrowly focused. So some of the barriers to adoption I put on this slide. There are many barriers, but they include lack of awareness of the potential value of community health workers, both their limits and their capacities, and how to integrate community health workers in care delivery models and care teams. There has been some scepticism and negative attitudes of some other health staff about community health workers, particularly when there's been concern about them taking clinical roles, which of course is not what we're suggesting, but also concern about the sort of level of competency they can have with fairly brief training programs. There's a lack of standards for community health worker selection, training, scope of practice, roles, responsibilities, workload, reimbursement, and clarity around what are the important outcomes to measure. So what difference can they make? Some of the sorts of things I talked about earlier in the talk. And lastly, of course, a lack of financial reimbursement for services, which has been a key to making their sustainability. One of the most important enablers of community health worker programs, both in Australia and overseas, has been in their engagement with their communities and key stakeholders. Those with experience both as consumers and as fellow health workers need to become advocates for the adoption of community health worker programs in health services and organisations. And again, in the US, probably the strongest advocate for, apart from the Community Health Worker Association itself, has been the American Public Health Association, which is, again, because of the key role that it's seen community health workers play in addressing health equity. So where do we go from here? Today, as well as reviewing some examples of community health worker program, we'll discuss some of these challenges and these issues. Where do community health workers fit within the health system? Should they continue to be narrowly focused around particular disease groups or particular population groups? How do they fit within levels of government and government or non-government organisations, and where should the training programs and supervision, for example, sit? How do we create sustainable training and supervision models? What are the financing models? And do we have an alliance with communities and community health workers themselves to take this forward? I want to acknowledge at the end of this talk all the work that's been done on this by many people, including many of the people in this room, and but particularly to acknowledge Liz Harris, who has been the driver for the development of our work on community health workers in the centre.